Good day. Welcome to the third annual Natural Health Expo, sponsored by Holistic Made Easy. I'm Dr. Tom Lewis, medical scientist from Health Revival Partners, and I'm going to talk about COVID-19 and particularly America the Vulnerable, why our population is arguably the most vulnerable towards COVID-19. The first thing that I want to discuss is really beyond the mask. What we have in America is a situation we have an opportunity with COVID-19 to understand why people are vulnerable, who are immunocompromised, and instead, the only protection we're offering the individual is the mask. And I think we can do significantly better. So, does the mask even provide significant help? I think it provides more comfort than it provides actual scientific health. Here's a study from Health Affairs where the daily growth rate slowed by 0.9 percentage points when there was a mask mandate. And after 5 days, or after 3 weeks rather, the daily growth rate had slowed by 2 percentage points. That's actually a rather meager improvement in reduction in COVID-19 severe cases. But what about other things that can make us resilient to COVID-19? So here's a conundrum we face in America. This is a chart of life expectancy, years lived on average, versus healthcare expenditure. And what we can see is, and this is a chart of the major developed nations, including the United States, Austria, Netherlands, Switzerland, Japan, countries like that. And here we can see that other developed nations spend about 1/3 of what America spends on healthcare, yet they live up to 3 years longer. So we really have an American conundrum. This is from 2018 data from the Organization of Economic Cooperation and Development. So we really have a conundrum, and most of these costs in America are for expensive procedures and expensive drugs. The procedures and drugs are not making us healthier. They're making our bank account weaker, and we're not living as long. So that's a real problem. And this delta, this difference between longevity, is really an expression of our vulnerability to chronic diseases and diseases like COVID-19. So you can see, really, what this chart is telling us is the more we spend on healthcare, the shorter our life expectancy. So this is from the CDC, and what we're seeing is that 6 in 10 adults in the U.S. have at least one chronic disease, and 4 in 10 have more than one. And chronic disease is the leading cause of disability and death in America, and it's costing us around $3.5 trillion annually. So it's a significant problem in America. And as we well know, and as I'll show you, that your chronic disease burden is a major indicator of your risk of severe COVID-19 or actually dying from COVID-19. So the problem underlying all these chronic diseases, and this is from the Washington Post this year, is that chronic inflammation is present. And the trouble with chronic inflammation is it's long-lasting, insidious, dangerous, and you may not even know it. What I tell my participants is, let's say, for example, I jab my hand and it's going to become bruised and even bloody. That's an acute disease, but I'll recover from that. But let's say I just keep rubbing the back of my hand 24/7 with this eraser. What'll happen eventually is that the insult, the harm created on my skin, will actually be worse over time when I just continuously provide this low-grade inflammatory process to my skin. So that's what chronic inflammation is, and that's what really chronic disease is. And that's what we have to recognize is driving most of morbidity, disease, and mortality in the United States, and making us vulnerable to COVID-19. Now here's an interesting chart that was published this year in the Wall Street Journal, and it says despite all the medications and treatments we have for heart disease, we actually have an increase in heart disease from 2011 to 2016, with places like Lexington, Kentucky going up by 27, almost 28%. This is an increase in cardiovascular mortality. Apparently, healthy places like Colorado have a huge increase as well. And we're in America where a large number of people are taking preventative cholesterol-lowering medications, yet heart disease mortality is going up. So there's an incongruence here. It's not really working. And since that period of time, the last 5 or 6 years, the total death rate from cardiovascular disease is up across all of America by 4.3%. This is an unacceptable trend. We need to do something about that. People with cardiovascular disease, as I'll show you shortly, have very high mortality from COVID-19. Here's the chairman and CEO of Kaiser Permanente, the largest private health organization in America, in California. And here Bernard Tyson, at the age of 60, dies unexpectedly in his sleep of a heart attack. Here he has all kinds of health resources based on the standard of care, yet he dies suddenly and unexpectedly. I'm going to explain the model that helps us understand why someone like Tyson would be vulnerable to cardiovascular disease, yet the standard of care is not picking up on it. Here's some other people who've died suddenly who were very prominent. Jimmy Lee on the left, the top investment banker in the world. Tim Russert, Meet the Press. David Goldberg, who's the husband of a founder of Facebook, died suddenly. And we have the CEO of McDonald's, dies suddenly at a relatively young age of heart disease. And other people, the head of the health coach for The Biggest Loser, and the gentleman on the left, lower left, John Warner, president of the American Heart Association. He didn't die, but he had an unexpected heart attack while at an American Heart Association meeting. And the headlines was, Dr. Warner experiences a mild heart attack while at the American Heart Association. But when they interviewed the EMT who saved his life, said his heart had stopped for 7 or 8 minutes. So we have a new definition of a minor heart attack. In reality, he had a massive heart attack. You can be guaranteed he's on a statin cholesterol-lowering drug, probably a blood pressure medication, and it's not working. So these are the lifestyle risks for chronic diseases: heart disease, cancer, lung disease, stroke, Alzheimer's, diabetes, chronic kidney disease. This is from the CDC. These are the major chronic diseases we experience in America. And no surprise, these conditions are what lead to really poor outcomes from the SARS-CoV-2 virus and the COVID-19 disease, with cardiovascular disease leading the list. So, for example, if you have cardiovascular disease, your likelihood of dying from COVID-19 is 10.5% compared to 0.9% for a person with no health conditions. And these numbers are skewed because it's based on who is actually testing. The overall numbers are a lot lower, but the point is, going from no health conditions to cardiovascular disease is a 1,200% increase in death from coronavirus. Okay? And we're all waiting for the vaccine. But in 2020, or 2019 rather, the flu shot was only 58% effective. So going from having cardiovascular disease to having no health conditions is a 95% improvement, at least, whereas a flu shot is only a 58% improvement. So what improves your odds? The mask at 2 or 3%? The vaccine at 58%? Or becoming healthy? 95% improvement in resilience against COVID-19. So all these diseases, the reason why there's an overlap between cardiovascular disease and COVID-19 deaths, diabetes and COVID-19 deaths, respiratory conditions, so on and so forth, all these diseases present with elevated cytokines. And a cytokine is immune response or a signaling molecule. And the true expression is very simple. Activity of your immune system or inflammation, which is the exact same concept. So, Mass General, learning about COVID-19 from studies in China, determined that they could triage people by doing specific blood tests. And sadly, these blood tests, which really are measuring, say, clotting or innate immune response, things of that nature, aren't done in the standard of care. So you can look up on Google the Massachusetts General Hospital COVID-19 treatment guidance and find a very extensive document that Harvard Medical School is using to risk stratify people for COVID-19 who are in hospital. But let's say you're not in hospital and you want to know your risk. These exact same tests will tell you your risk for future COVID-19 severe symptoms. So they're looking at a complete blood count, looking at the lymphocyte count particularly, because lymphocytes tend to be depressed when you have a viral burden. Fasting insulin, metabolic things. CPK, which is measuring tissue deterioration. Ferritin, iron storage. CRP, which is inflammation. Fibrinogen, a clotting signal molecule. D-dimer, clotting. SED rate, a general measure of the electrical system of your red blood cells. LDH, another one looking at tissue damage and repair. IL-6, which is an inflammatory cytokine, and TNF-alpha, another inflammatory cytokine. So your status for any of these markers, before you have symptoms, before you've been infected with COVID-19, or if you have COVID-19, any one of those three, will tell you what your risk is for the severity of the symptoms. The other thing that Harvard's doing is looking at baseline virals, Epstein-Barr, herpes simplex virus, other viruses. So your pre-burden of viruses you may not even know you have will determine your risk. And bacterial titers. This is what Harvard's doing today for people in the hospital. This is why azithromycin helps in COVID-19, because every one of us has a pre-existing bacterial burden. Think about it. When you pass, you're no longer interacting with the environment, yet you start decaying. It's happening from within. So we all have baseline bacterial burdens, and this is what Harvard Medical School is doing to triage COVID-19 in hospital sick people. But these same tests are what you should be doing to determine your current vulnerability. Never mind the mask, how susceptible are you? And then, of course, what can you do to make yourself less susceptible? I'll be talking about that as well. So this is a really interesting study that my team did, and we now published it. And yeah, it might be a little bit of a confusing graph, but once again, we're looking at the percent of people who die from COVID-19, and here's a percent on the x-axis. So none, pretty low rate, cancer, respiratory disease, heart disease, diabetes, and high blood pressure. And then this is a search of PubMed, the medical library, National Medical Library database, for the relationship between infection and these various diseases. And this is the number of papers in millions. So there's a huge number of papers out there. So you can see if you search PubMed for cancer and infection, you find 6 or 7 million publications. Heart disease, 10 million papers. And when I correlate these numbers, you see that the level of studies on infection versus the death rate from COVID-19 has a startling match. What this is telling us is that pre-existing infectious burden tied to these diseases, which heretofore are not considered infectious disease, but really are. It'll take me a while to probably prove that to you, but I have many, many studies on this and published 3 books and multiple papers on this topic. But there's a profound connection between baseline stealth or hidden infectious burden, including virus, including bacteria, including mold, things of that nature, and these conditions. And then there's a profound connection between these pre-existing conditions and your risk of dying from COVID-19. So what this really begs for us to understand is that we are neither healthy nor sick, that we all lie on a continuum, and I call this, the major continuum of health and disease. And when you understand that everybody lies on a continuum, so for example, the death rate from cardiovascular disease is 10.8%. So a lot of people don't die who have cardiovascular disease, and a lot do. So cardiovascular disease is a subjective measure of health, because you may have someone with cardiovascular disease that dies today, and you may have a similar type person who lives for another 30 years. So cardiovascular disease is a subjective term. But what really is going on in cardiovascular disease is, what is your underlying physiology telling us? What are your inflammatory markers? What's your vitamin D status? All these markers that really create the portfolio of your risk and place you on a health disease continuum. When you understand that everything in health and disease is on a continuum, subjective human-made terms like diabetes and cardiovascular disease become irrelevant. It's really where you are on the continuum. Are you on the bad side of the continuum or the good side of the continuum? And in fact, when we look at immunocompromised status for COVID-19 and chronic diseases in general, we look at 4 different continuums. You have a risk continuum. What was the circumstance around your birth, your childhood, your nutrition, your exercise, your life risk status. These are the important things that really measure your health and disease and where you are on the continuum. The next is a physiological continuum or a blood continuum. So when your risks are on the wrong side of good, and they are perpetually such, going to McDonald's every day for a breakfast sandwich, for example, then slowly you may see changes in your physiology. And these aren't the standard of care, the simple A1C or the lipid panel. We're looking at inflammatory markers. We're looking at smoldering changes in your blood portfolio. The next is pathology, tissue changes. So when your risks are bad perpetually, leading to physiological or blood changes, the next thing we're going to start seeing are changes in tissue. The blood will beget tissue changes. And these can be things like gleaned from, say, an ultrasound or a PET scan or an MRI. But I'm going to show you how the eye is a profound marker for changes in tissue that can be done very inexpensively. And then when pathology, tissue changes long enough, that's disease. So for example, a stroke isn't a sudden thing. The tissue has been deteriorating for a long time and may lead to a hemorrhagic stroke where the blood vessel actually breaks. That doesn't happen suddenly. There's a long lead up to that process. Or an ischemic stroke, where there's a plaque buildup in the tissue and suddenly at some point the blockage becomes profound enough to prevent blood flow to that downstream tissue, and we call that an ischemic stroke, for example. So here's the artificial line here, where we call people on this side healthy and this side unhealthy. And we have a really hard time getting people to be proactive about their health. Reactive, you have cancer, you have a heart attack, you have a stroke. We become more proactive. But really what you can see is it's just an artificial position where suddenly there's some sort of a manifestation, but the lead up can well be predicted by looking at your risk portfolio, by looking at your physiological status, by looking at pathological changes, and then measuring other chronic conditions you may have been diagnosed with. That really tells the story of your health. So really, what I want to talk about now is COVID-19 and biomarkers that are useful for predicting your risk from risk of severe COVID-19, and they completely overlap at predicting your risk of cardiovascular disease. So The first is your lifestyle and environment, and look at this as a risk severity scale for that. We measure that very accurately with a online survey that we call your chronic disease assessment. And the interesting thing about this tool, which is available on our website, healthrevivalpartners.com, is every question and answer has a risk score. So we can give you an aggregate score and very quickly tell what areas in your lifestyle and environment are most out of whack that can lead to a perpetuation or elevation in blood labs. So here's an example of our risk continuum dimension 1. It's a long survey, but a valuable one, and we color code all the answers. So here we're simply asking in the end of our survey about different conditions you have, and so this would be continuum dimension 3 or 4, what chronic conditions do you have? But we give you an overall grade, and the important thing about this survey is we give you a path to improve your risk portfolio. Now, blood markers, we're all on a continuum, and what we have to realize is that in the standard of care, the reference intervals used to determine whether you're healthy or sick are based on populations. People going into the doctors, people going into LabCorp and Quest and getting measured. Knowing what we know now about America and our health status and chronic disease status, do you really want to be measured against people that are already sick? So we've created a whole new scale for normal based on a statistical increase in early mortality. And what that does is it dramatically tightens the range. So let's just say for white blood cell counts, the most profound and simple measure of your innate immunity. If this is the reference interval of normal for the standard of care, our reference interval is much tighter. This is looking at flamingly bad health. This is looking for the smoldering or the smoke before the fire. So this is what our report looks like. And this is not a complete report. Our report for the physiological continuum, dimension 2, is 12 to 15 pages that really articulates what each lab means. But most importantly, it's the story of health that the labs are telling. So for example, this top line is diabetes risk, and we can see a high A1C, a high glucose, high insulin. And we give a risk score on a 0 to 10 scale, which reflects that continuum. And in this case, this person is well up that continuum. You'd probably like to be on a scale of 0 to 10, 1 or less, whereas their heart disease risk is relatively low, their stroke risk, cancer risk is a little bit elevated, so on and so forth. So this really helps place where you are in that continuum and the disease, various disease or tissue disease status continuums. Now, tissue markers will progress after your risks start progressing and your blood starts changing for the negative. And what we do is very unique in the industry. We use the eye as a way to measure tissue changes. So the classic eye diseases that you may be diagnosed with, cataract, macular disease, glaucoma, these are all associated with tissue changes in the eye. And the interesting thing is in the back of the eye and in the front of the eye even, we can see vascular changes and we can see neurological and neurodegenerative changes. So here's a case published in the New York Times about 3 years ago, Ebola's legacy, children with cataracts. So what they said is cataracts usually afflict the old, but doctors in Africa have been shocked to find them in Ebola survivors as young as 5 years old. So here we see a nuclear or the classic cataract that affects vision. And if you read this article on Ebola's legacy, you'll see 20-year-old, 30-year-old teenagers undergoing cataract surgery. But what does it mean? What does this article mean? Ebola cataract. Infection cataract. So cataract is a tissue change in the eye, which is actually a barometer for, in this case, an acute infection, Ebola. the Ebola is causing an innate immune response, which happens to manifest as a cataract. So let's take two 60-year-olds, one with cataract, one without. Do they have an acute affection? Probably not. They probably have something chronic going on, leading to this, what I call a tertiary immune response, this unfolded protein response that manifests as a cataract. So let's look at what cataract really means. This is the age-related eye disease study, and it was done by the National Institute of Health. And by the way, since this was done in the 1990s, 16 other studies have been completed now, all of which come to the same conclusion. Cataracts and age-related macular disease, both which show pathological changes in the eye, are a sign of early mortality. And essentially, everybody with these conditions has extraordinarily high mortality, equal to a diagnosis of breast cancer from cardiovascular disease. So here we can see vision change, a sudden vision change, which means the beginning of a cataract. Now we see the cataract, nuclear opacity. And here the cataract is so bad that we have to have cataract surgery. So we see this progression from a 36% increase in mortality to a 40% increase to a 55% increase in mortality. So there's a significant increase in mortality just from the fact that we're seeing a tissue change in the eye associated with an innate immune response, most likely tied back to chronic infection, as I indicated, based on the Ebola study. I want to show another manifestation of the genius of the eye in diagnostics. Here we see the prevalence of Alzheimer's with age, and here we see the prevalence of glaucoma, or plaques in the back of the eye associated with glaucoma and macular disease. And we can see the onset is 15 years earlier than the onset of the Alzheimer's. So the eye and tissue changes associated with neurological processes is actually a future predictor of Alzheimer's disease. And everybody should be screened early and often for eye pathologies. And then do blood testing and risk testing, which isn't happening at your eye doctor, but this is a sick eye and a sick body. So when you have a progression like this in the eye, you need to look back on what's going on in your life to prevent this from progressing to a more serious disease like Alzheimer's or cardiovascular disease or stroke, things of that nature. So the eye is truly an extension of the brain, and here's Professor John Darling at Harvard, chaired professor, who talks about the eye as part of the brain, and the retina, the back of the eye, is an approachable part of the brain. It's transparent. We can see it very easily and very inexpensively with instruments that many optometrists and ophthalmologists have in their practice. Here's a very interesting thing, a sick eye and a sick body. This is a misfolded protein known, based on Harvard studies, to be associated with Alzheimer's disease. And what we see here is what's called a fibril of the beta 142 amyloid, or the plaque in Alzheimer's. Here's from my mentor's practice, Dr. Clement Tremp at Harvard, who took a picture of a living patient looking at their lens of their eye and seeing a structure extraordinarily similar to this structure in someone who died from Alzheimer's disease. And in fact, Harvard did studies like this and showed that when they pulled this so-called plaque or misfolded protein or fibril out and analyzed it chemically, that they're the exact same thing. So the front of the eye, the lens, is able to predict plaques in your brain associated with Alzheimer's. Here are some of the papers that we've published. The first one is a disease mitigation and elimination health learning engine. This is a patent that basically talks about how your risks beget blood changes and how blood changes beget tissue changes leading to disease, and how we can look at these things as a continuum and integrate them so that we can use the risk scoring to help improve your blood. So improve your tissue changes and reduce your chronic disease burdens. Then we published a paper on this called The Reduction in Chronic Disease Risk and Burden in 70 Individual Cohort through Modification of Health Behaviors. And what we showed in this study is simply when we improve risk factors, and remember we give a grade from our survey, so when we move someone from a D to a C, their blood improves, and oftentimes chronic disease complaints and disease diagnoses improve as well. And then here's a paper that Dr. Tremp at Harvard and myself wrote. It's Never Too Early or Too Late, End the Epidemic of Alzheimer's by Preventing or Reversing Causation from Pre-Birth to Death. So in other words, even in pre-birth, in the womb, there are things that can affect the development and future health of our brain, and in fact, our whole body. So protecting your brain and protecting your overall health is a lifelong pursuit. And understanding where you are on the health disease continuums is a major component of heading in the right direction. So here's from the study we did that was published on 70 individuals. And what we have is the chronic disease assessment risk grade from A to F, and it's simply what we call Dimension 1, your risk portfolio. It's the myriad of little risks. And what I say up here is making small and manageable changes leads to big health improvements. And here's Dimension 2, your physiological risk score, which we call your chronic disease temperature risk score. And as you see, as we move someone down the risk portfolio score, their blood changes for the better as well. And this is actually a study of 240 individuals, which will be subject to a new paper we're in the process of publishing. Here's some typical outcomes. Here's a gentleman, he took his own pictures in 2017. Severe rheumatoid arthritis, he claimed he could not really close his hand. He's a machinist, so he was on disability. And in a scant 5 months, significant improvement, and his testimonials on our website, able to move his hands, lost 25 pounds, no longer type 2 diabetic. So, and this is just from doing small minor things. Recognizing his physiology was bad, recognizing he has tissue changes, look at those joints, but changing risk factors is what really led to this change. Here's a lady with psoriasis, been to multiple dermatologists, treated topically, treated with infrared light, all kinds of techniques. All we did was got her off her cholesterol-lowering medication, and cholesterol is extremely important in repair and recovery, and building tissue and membranes, and improving her diet somewhat. And in the same time frame, 5 months, we see significant improvement. This talk is about COVID-19 and chronic diseases. And I want to offer you folks an opportunity to understand where you are in the COVID-19 continuum. So we offer a myriad of a number of blood panels. Our chronic disease temperature is our flagship panel, which we use to really measure where you are on the health disease continuum for physiology. We also offer various other panels as well. But we also offer COVID-19 detailed risk and screening based on what Harvard is doing to triage in-hospital COVID-19 patients. So we're doing the various tests that look at tissue deterioration, clotting factors, inflammation, cytokine storm. We have all these tests available to you. So what provides the best protection for you? The mask, 2 to 3% reduction in populations when they're used rigorously and judiciously, or improving your health. And I would argue that going from a cardiovascular disease status to healthy is a 95% protection factor. Well, this may only be a single-digit protection factor. So it's really your choice. And what I believe this does is highly empowers the individual to know they have the COVID-19 and their chronic disease risk under control. Whereas this is a Band-Aid, typical of medicine, it's a symptomatic treatment, and it's not ultimately solving what you want, resilience against the infection and the disease, which overlaps in so many other areas. The next pandemic, the flu, cardiovascular risk, all these different risk factors. So just as a reminder, the masks are about 2 to 5% effective at reducing COVID-19 cases. Being healthy is going to reduce that, for example, by 1,200%, a significant reduction, 95% on an absolute scale. And the current flu shot is only 58% effective. So improving your health is your number one empowering activity that you can do to feel you have control over your life in this pandemic circumstance. All these diseases present with elevated cytokines. Measuring lipid, cholesterol, not a really good marker. Measuring C-reactive protein, fibrinogen, clotting factors, this is what you want to be measuring to determine where you are on the COVID-19 and chronic disease health continuum. All the algorithms created here was developed by scientists and practicing doctors at MIT and Harvard Medical School. And it's all backed up by scientific literature, our own publications, which are highly citing the medical literature, and we've also written 3 books on related topics. So America the vulnerable. It doesn't have to be this way. If we get out of the pill mentality and work on improving our health, focusing on our life risks, mainly because it's the life risks that lead to all these other changes that makes us vulnerable, then we don't have to fear this and the next pandemic. I'm Dr. Tom Lewis, medical scientist with Health Revival Partners. I really appreciate your time. Thank you very much.